Hello, everyone, and welcome. I am Sally Davies, Executive Editor of Aeon magazine, and it's my pleasure today to host Brochure's Meetup on the ethics of the care workforce. So globally, we all know that nurses and healthcare workers carry immense responsibilities, yet at the same time, they often lack organisational support, resources, and sometimes even respect. This can lead, among many other harms, to forms of moral distress, the damage suffered when you occupy a structural position whereby you are unable to do what you know to be right. The past few years have exacerbated the challenges healthcare workers confront, as we find ourselves at the intersection of recovering from a worldwide pandemic, nursing shortages, and the consequences of climate change, natural disasters, and geopolitical instability, all adding pressures on already overburdened staff. So against this backdrop, today's discussion aims to explore how nurses and healthcare workers can prepare for practice, how to foster more nurturing caregiving cultures for staff and patients, and how codes of ethics align with on-the-ground realities. What policies and paradigm shifts could enable a workforce to confront the rising complexity of modern care practice? How do we uplift caregiver wellness whilst delivering high-quality, ethical care for all? So some housekeeping matters just before I ask the panellists to introduce themselves. The meetup will last for approximately 1 hour. In the first half hour, we're going to hear presentations from each of our panellists, and in the last half hour, we'll open up the floor for discussion. So please feel free to drop some questions in the chat and we'll try to respond to them as best we can. So I'm just going to go around and ask our discussants to introduce themselves, starting with you, Anne.
Oh, good afternoon, everyone. Anne Gallagher, Head of Health Sciences, Brunel University, London, and I'm also editor of the journal, Editor-in-Chief of Nursing Ethics. Thank you.
Thank you so much, Anne. Elizabeth.
Hello, I'm Elizabeth Peter. I'm a professor at the Lawrence S. Bloomberg Faculty of Nursing and also a member of the Center for Bioethics at the University of Toronto.
Thank you so much. And finally to you, Howard.
Hello, everyone. My name's Howard Catton. I'm a nurse and the Chief Executive Officer of the International Council of Nurses. We're the body recognised by WHO and other global organisations to speak on behalf of the nursing profession, and our membership are national nursing associations.
Thank you so much, and thank you to everyone for being here. So to start off, we're going to hear some brief presentations, beginning with you, Anne.
Thank you. Can you see that? Yeah, fantastic. Thank you. It's a pleasure to be involved in this panel discussion today, and I look forward to engagement after our presentations, and particularly to work with Elizabeth and Howard. So my 6-7 minutes is just to give an overview of some of the key questions in relation to ethics in the care workforce. And as you know, there are huge challenges. Oh, excuse me, just go back. Okay, better. So yeah, many challenges. And I guess this is the dominant narrative of crisis in care. And you can see some of the headlines. These are primarily from the UK. To that end, in the UK, as many of you will know, we have a National Health Service set up in 1948 with great hope and optimism that the health of the nation would improve and the need for health and social care would decline. But of course, the good news is people are living longer, but alongside that, people's needs are increasing. We have many more multimorbidities. So the demand is increasing and our resources are limited. So there are at least 4 pertinent question areas, and I'm pretty sure Howard and Elizabeth will engage with these areas as well. So I'm just going to make a start on just sharing these 4, I think, very critical questions. We need to engage.
Sorry, Anne, I didn't mean to interrupt you, but I think it may be the same for everybody that we're just seeing the cover of your presentation at the moment rather than the actual slides. So I just wanted to stop you there. Apologies for the interruption.
Okay, not at all. Let me try again. Try and screen share. Okay, you can see. Can you just see one or all slides?
So we can see the slides down the side. It's not in full screen mode at the moment, but I can see the slide. And if you just move down, let's test.
Yeah, maybe start the Yes.
From the beginning?
Yeah. Click on it if it's working.
Better?
It's actually charging.
Oh, it seems to be loading.
Yeah.
Is it moving?
So on our screen at the moment, I just have the cover.
Yeah.
Okay.
So
Okay.
I think you could just, it's perfectly fine if maybe just quit and relaunch one more time.
Exactly.
And if it's not full screen, that's fine. Like if it's just like this,
Yeah,
I think that's
I think given the time, Sally, I'll just go with this if you're
Please
okay
go
with
ahead.
this. Okay, thank
Absolutely.
you. Not at all. So as I said, the dominant narrative has been crisis in care, and in the UK, we've had this NHS long-term workforce plan with great optimism and hope that we can increase the workforce. And you'll see the aims of that is to grow the workforce. And part of the narrative as well is growing our own. There's a attention to the fact that in many countries such as the UK, there's a lot of recruitment from overseas. So that's something we will attend to maybe in the discussion later. They want to retain existing talent and work and train differently. There's a movement in the UK towards apprenticeships. So rather than people coming into the university full time, there's been a significant movement towards people staying in their practice area and then coming into the university part-time, which has many benefits, and also having more flexible teams and new roles. So as I mentioned, the 4 questions that seem most pertinent to this conversation are the issues of recruitment. Significant challenges recruitment to health and social care for many reasons that I think will emerge in the course of our conversation today. Significant challenges in selection to the care professions. As I'll mention in a moment, our young people are not the same, I guess, as we are, so we have to attend to individual differences and complexity, but critically attend to the ethical climate of the organisations, the health and social care organisations people work within. And then related to that is preparedness for professional practice. How do we do that? What does our professional education processes look like? How do we best prepare people to be fit for the complexity and diversity of health and social care systems and processes? And then the 4th one, which is a significant challenge around the world, is retention. We may be able to recruit, select, and prepare, but in many areas, people are leaving, and there's huge gaps in our workforce in the UK and globally. So one of the things I said I'd focus on is the relationship between individuals and cultures of care. And historically in ethics, the focus was on individuals. We talked about sort of good and bad professionals. But more recently, there's been a significant and very welcome move towards discussions of the ethical climate, the moral climate of organisations. But that said, although last year we celebrated the 30th anniversary of the journal Nursing Ethics did not begin 30 years ago, of course. And there's a book that's just about to be launched by Marcia Fowler, which traces nursing ethics back to the 1880s. And I had the pleasure of reading some of those early texts. And whilst they didn't discuss ethical culture the way we do our moral climate, they did talk about something called atmosphere. So that was really interesting. So even then, there was an awareness that the culture of the organization was significant in terms of promoting ethical practice, or indeed bad practice could happen within those cultures, if you see what I mean. So recruitment to the care professions, critical question, what do young people want? There are generational differences. We've spent quite a lot of time focusing on Generation Z. I did a study a few years ago with colleagues in Russia, Ireland, and Japan and England, and we interviewed young people who were 13 and 14-year-olds, and it was incredibly instructive and informative and really very interesting. We used a photo voice methodology where they brought photographs and artifacts that represented care. And just on the bottom left, in terms of their view of how they conceptualized care, they were incredibly thoughtful and reflective. So they talked about the need for action, of presence, of operationalizing value. So their approach was very attuned with ethics. Then when we asked them about the objects and subjects of care, it was much broader than care for other humans. They also talked about other species, and they talked about the environment, tremendous sensitivity to the environment. They also were very aware of the challenges of care, the disincentives, the stress and the responsibility. And you can see on the right-hand side, in the UK, we've had strikes recently, and I'm fairly confident that did not help us to portray a positive representation of health and social care professions for our younger generations. And I think we'll probably come back to that. But these young people also could see the value. They were very appreciative of care work, the appropriate rewards, the diversity, the range of care careers that people could have. And also critically, what we would like them to say, and what they did talk about, was they were aware of the difference that a good care worker can make to the lives of individuals, families and communities. So that was very gratifying and very, very heartening. Just at the bottom, I put, it's one of the debates we might engage with, and perhaps Howard and Elizabeth might pick this up as well. There's an ongoing debate about the ethics of professional migration of colleagues coming from the global south, for example, to the global north. And then also here locally in London, our partners talk repeatedly about the importance of growing our own. So again, that might be a debate and possibly a tension we might return to. The secondary student selection to care professions, an ongoing debate as to how we select students. And again, after the Francis report, some of you will be aware in 2012, 2013, there was a very major care scandal of the Mid Staffordshire Foundation Hospital Trust, where over 400 patients died unnecessarily, mainly due to misguided, we might say, organizational priorities. So that led to a discussion about values-based recruitment. And again, that has been greatly critiqued. But I think a critical thing we need to think about is the profile of our young people. And this was a very, very helpful report by Young Minds. And it leads us to realize that we need to be attentive to student complexity and their needs for support. There are generational differences, and we cannot ignore that. Young people are obviously not the same as us of an older vintage, dare I say. And they have different priorities and don't seem to want to work in the same way. So we need to be attentive to that. So in terms of the third question, preparedness for professional practice, ongoing debates about which educational and developmental strategies are most successful in preparing people, students, for the complexity of our health and social care services. So how do we do that? How do care organisations welcome and enable students and new registrants to flourish? And just two quick examples. I had a student recently who qualified last year, first-class degree, dual trained, went into practice, and within a few months she was on sick leave. She felt overwhelmed. She didn't have the support she needed, and she's now thinking about emigrating to North America, which was interesting and really very sad, because of course we would like our our students, our young people, our registrants to stay locally. And then the second example, another student who's just coming up to join the register, she had a recent experience in a hospice. Fabulous, couldn't have been more different, loved it, loved the culture, felt that she was supported by senior colleagues, and she also felt in tune with the values of the hospice. And she also talked to me about the role models she saw in the hospice, and she's already signed up to go back to work in that place in the hospice. So again, there are different organizational cultures which impact retention of our new registrants. So I'm nearly there. Retention is an ongoing issue, and as many of you will know, there's been much discussion of resilience, and we need to be very critical about that concept. Some people, it seems, might take it to mean that it means individuals doing more and more with less and less. That is not what it means from an ethical point of view. I'm pleased to say there's a lot of very, very helpful literature on moral resilience. And here I've given some examples. Cinda Rushton in the United States has done a lot of work to measure, promote moral resilience, and also develop toolkits to help us to enact that in our care organizations. In the UK, Michael Traynor, who's a social scientist, has done a lot of work, and you can see there his stories of resilience in nursing, again, a very positive portrayal. And also he adopts a very critical approach. And of course, when we think about resilience, it's not just the, in fact, it's a responsibility of the organization as well as the individual. It's the interaction between the two. And you'll see there's been a significant literature in nursing ethics on ethical climate. And there's a recent systematic review in nursing ethics that may be of interest. And I'm very happy to share the slides after. And then on the left-hand side, bottom left, is a very a very inspiring text from Canada, actually, towards a moral horizon. Leadership is absolutely critical in all of this. Leadership at every level, leadership in organizations, leadership at the national level. And of course, Howard has demonstrated and will, I no doubt, talk about the role of ICN in that. So just to finish, on the right-hand side, you can see we, just again to reiterate, I think these areas are critically important. We need to pay attention to individual students and professional caregivers, their complexity, their needs, their aspirations and resilience, and that is necessarily supported by care and education organizations, ethical cultures which set students and professionals up for success. Very, very important. We also need to continue with co-production with families, patients and communities. Professionals don't work in a vacuum. They necessarily must provide the service that patients, families and communities need and desire. And we need to flip the narrative. We need to get away from ongoing, repeated dystopian crisis stories and focus more on allyship, activism and success indeed. And of course, that requires political engagement and influence. And our nursing organizations and our professional organizations, nationally and internationally, are absolutely critical. And just to finish on the left, I couldn't really finish without a quotation. And this one is from Joan Tronto, who's written a lot about care ethics. And I'll leave you, it's in green on the left. So it's from a very small book she has, but it's a very, what would I say? It's a very inspiring text. It's called Who Cares? How to Reshape a Democratic Politics. So I'm going to leave you with that. And also just to finish by saying we have a conference here at Brunel in August on this very theme. So you'd all be very welcome to attend. So I'll stop talking now. Thank you very much. Thank you.
Thank you so much, Anne. That's fascinating. And actually, I did have the pleasure of moderating a panel with Cinder some months ago now, which can be found on the brochure website. So I'd really love us to return to this question of moral resilience. So I'll turn now to Elizabeth, who will do our second presentation. Elizabeth, I'll just double check that you're not on mute here, because I can't hear you, but it might just be that you're working in silence. Ah, yes, you're unmuted.
Okay,
now.
sorry, I lost my little little tabs. So thank you so much, Anne. And you've set up what I'm going to talk about really well when you talk about flipping the narrative. Instead, I called it mind the tagline. So as I was preparing for this, what came to mind is that throughout my career as a nurse, which is quite a long time, there has been this struggle for respect. And so I'm going to be looking at how we can foster respect, but we need to be careful about the narratives or the taglines that we use. And so I'm going to do this in a couple ways. I'll provide a very brief introduction to what I mean by respect, and then I'll give 4 examples. Okay, so why defining is important. Again, my go-to source, not just because Howard is here, but the ICN has great documents about why it's important to define what we do, no matter what profession, in terms of what we communicate to the public, to patients, and to ourselves in terms of how we organize education and research and so on. We know this is a crisis point, and so now defining and how we define what we do is really important. There is so much public awareness right now, at least in Canada. I can't turn on the news any evening without hearing about some crisis that we're having either in nursing, medicine, terrible shortages, and so on. So this is an opportunity to show what we can do. It could be time for practitioners to work to full scope. It can also be perhaps a time to expand scopes of practice. And as somewhat of a cautionary note, but this is going to be a mixed message here, we have to be careful about the unregulated care workforce for everyone in terms of how they come in perhaps to substitute for care that is more skilled and so on. That being said, with the appropriate skill mix, this workforce is extremely important and is deserving of respect. It's a huge part of our nursing home and home care system, I know here in Canada, and they are very much the backbone, and they are very much deserving of our respect as well. Okay, so I'm going to be throughout this working with two definitions of respect. This will be the only theory part, but I need to toss this in. Philosophically, respect is defined in multiple ways. One way is to speak of recognition respect, and that's the kind of respect all humans deserve just because they're human. It's the foundation of human rights and so on, and you'll see recognition respect throughout codes of ethics. But there's also another kind of respect, and that's appraisal respect. And this is the kind of respect that people or professions have because they're appraised in a sense that they're able to do something. There's some standards. They have the knowledge, skill, and judgment, for instance, for public safety, or they fulfill an important need in the healthcare system. So there are two types of respect I'm going to be talking about when we look at various taglines or narratives that are being used in the health professions. The big one throughout COVID, and I think this is international, certainly big here, were the COVID heroes and the COVID angels. So on the one hand, it may seem like a compliment to be called a hero, but if you look in terms of recognition respect, it's not. It's very destructive, actually, because through some work that Sean Mohammed and a number of us conducted, and this was more of a Foucauldian analysis, which I won't get into, there's a notion that the hero risks themselves for the greater good of others, and that does not promote good working conditions. It fosters an idea that practitioners should perhaps sacrifice their own well-being. The angel, very close tagline or narrative, has quite a long history in nursing. Angels are not human. They engage in acts that are supererogatory. They're beyond what humans should be able to do. And they also have no needs, which is not realistic for any healthcare provider. And also, it's a total setup for moral distress because nobody could meet the ideals of an angel. So there are recognition, respect issues here, even though on the surface it may sound like a good news story. The next one, which is closely related, I'm going to call this caring and virtue script. Virtue script comes through the work of Gordon and Nelson, and often, especially nurses, are simply called as the caring profession. This has been critiqued because it doesn't bring the kind of appraisal respect, because it's not viewed by most to have the necessary knowledge and skill to bring that kind of respect. And it's built on this historical stereotypes. It may on the surface sound great because we're the most trustworthy, so to speak, or that's been sold. But ultimately it is problematic because that appraisal respect isn't there. As a huge footnote, however, as you know, an ethicist, caring and virtue, when described in philosophical depth, very much are about knowledge, skill, and judgment, especially Aristotelian virtue ethics and so on. But for the general consumption, this is not the route to go. The third one, and I think Anne spoke about this a little bit as well, is this notion of the wounded carer. So there's a lot of emphasis on things like burnout, moral distress, and so on. That's true. And in terms of recognition respect, it may bring about an understanding that the workforce has a right to better working conditions. Yes, so in some instances, but from appraisal respect, this could be damaging. And I had this insight actually a few years ago. I was hearing an Indigenous scholar at the University of Toronto, Eve Tuck, talk about damage-centered research that's really common in Indigenous research in Canada. And what she said, and this is a quote from her, she says, damage-centered research reinforces and reinscribes a one-dimensional notion of people as depleted, ruined, and hopeless, which is something we want to avoid in terms of an overall appraisal. It's a nice soundbite, but we need a bigger picture. And the last one, which is the one I think that doesn't get critiqued, but I notice all the time, is the notion of the evidence-based practitioner. On the one hand, yes, it conveys appraisal respect because it's about people who have a, scientifically informed knowledge, skill, and judgment. But with the dominance of STEM, what has happened is, and I've noticed this over the last 20 years, is there's an overshadowing of other kinds of knowing. Ethical knowledge, there's a decline in philosophical ethics and the importance of the humanities. So on the one hand, this may initially bring appraisal respect, but it could eventually erode any of the healthcare professions if we somehow decline in our ethical conduct. So very quickly, what do we do about this? I think it's sort of an easy answer. Use longer definitions when conveying things to the public. And I've put the short definition that I pulled from ICN, and you'll see the short isn't that short because it's impossible to convey the richness of any profession, including nursing. And so the short definition even starts to get at the complexity of what we do, which is a better message to the public. And lastly, we don't stand on one value either. There are multiple values. Again, something I've pulled from the Code of Ethics. I think there are 29 values here. We're not simply one thing. Even though it may sound nice to simply wrap it up in a few words, it conveys the wrong message, and I'm concerned about the ultimate implications for respect. So thank you.
Thank you so much, Elizabeth. That's fascinating, and I think dovetails really well with some of the questions that Anne laid out, which we can return to shortly in the discussion. But just to conclude this round of presentations, I'll now hand over to Howard for some further remarks.
Sally, thanks very much. And Elizabeth, I mean, you've set up the discussion and the debate beautifully and touched on many of the issues that I just want to make some few remarks on. And I'm going to try and make those remarks based on my reflections of conversations that I have had with a whole load of nurses from right the way around the world over the last couple of years. First thing to say, and Elizabeth mentioned our code of ethics. I've not got a presentation, but this code of ethics, if you can, it probably be difficult to see if I hold it up. On our website, www.icn.ch, and we'll put it in the chat for you as well, is the code of ethics for nurses. We first established our code after the Second World War. It's one of our most downloaded documents. A number of countries use it as their code of ethics. Some use it as supplementary to codes of conduct or other codes of ethics that they have as well. And we revised it just before the pandemic. Anne was a huge supporter and expert involved in that process, along with other eminent nurse ethicists from around the world. And that code says at its kickoff what you would expect it to say. Primary professional responsibility, the nurse, is to patients and to patients' needs, to put them first, to promote their rights, both as individuals, but within the context of the family and communities that they live, to provide care regardless of people's creed, colour, religion, or other defining factors, to respect confidentiality, to advocate for equity and social justice. I could go on, but I think until recently, often when people look at the code and they think, well, yes, it's really important. It's what we'd expect to see. And this is the motherhood and apple pie of how we want our health professionals to practice and behave. And yes, that's absolutely right. But my assessment based on the last 2 or 3 years is I don't think that there's ever been a more difficult time for nurses around the world to practice in accordance with their code of ethics. I think we set the bar incredibly highly and rightfully so. But recent events, and I'll go through some of the examples, I think have challenged that in a way that we probably haven't seen before. And the Groucho Marx approach to this is not open to us. You know, I've got principles, and if you don't like them, I have others. That clearly is not a road. It's not an option for us to go down. But I think that then pushes us to look very seriously at some of the institutional governance and social structures within which the profession works. We are seeing the impact on nurses, both in terms of recruitment and retention, intention to leave rates, people quitting earlier than they otherwise would have done, and specifically citing the impact of being unable to deliver care to the standards that they've been educated in accordance with the ethics that determine their practice. Let me say a few things based on those conversations from people around the world. Firstly, in relation to the pandemic, the physical toll taken on nurses around the world, the physical injury was overwhelming. We did work with WHO, which estimated that at least 150,000 healthcare workers around the world succumbed to COVID-19. I believe the true figure to be much higher. We had the woeful lack of PPE, the snail's pace at which the world was able to get the vaccine to healthcare workers, I'm not to everybody, but to healthcare workers in particular. And when our health systems crashed because they were not prepared sufficiently, and there were those decisions about who gets the oxygen, who gets the ICU bed or ventilator, it's not the planners, the policymakers who have to eyeball people stood at the door to an accident emergency. It's our nurses and it's our health care workers. And this is where we heard moral injury, moral distress, psychological harm being used widely around the world. But one of the responses we heard, Anne pointed this out, was either what we need is more resilience, suggesting in somehow that our health workers weren't strong enough, they weren't the heroes that Elizabeth says. It's very ably described the problems, the downfalls with using that with that language. Many nurses who said, Howard, enough, I've heard of the resilience training, just make sure that our health systems are stronger, and that's where the preparedness, we need a health system resilience. It's not about individuals. And also the suggestion that we might be, it's all snowflake generations. It's people who are a bit overly sensitive, sensitive as well. But I then move on to some of the current conflicts and disasters from around the world. I've been on calls with nurses in Ukraine, in the cellars, the basements of their hospitals, still providing care, and had to stop the conversation because we could hear bombing overhead. I've talked to nurses in Myanmar who are subject to attack because the military junta regard the fact that they're providing healthcare to people who they see as terrorists as unacceptable, whereas the nurses are saying we provide care regardless of color, creed, religion, or political affiliation. We've seen the destruction of health facilities and the targeting of health staff in the current conflict in the Middle East as well. And if I put all of these together, there is a incredibly worrying sense of almost the normalization of violence. So the experience of violence, it goes with the turf, it goes with the job. Even for nurses who, before disasters and conflicts, an accident emergency department on a Saturday night in a city in the UK or anywhere else in the world, people expecting that they're going to be subject to some sort of abuse. Where is that normalization come from? I don't think that we cannot ignore the links in the relationship with the issues of gender and stereotyping that still exists, and how that plays into the lack of value of what nurses do. But we've also seen more generally, if I again look at Afghanistan, look at what's happening in the Middle East, look at other conflict zones, this goes beyond nurses as the carers. It looks at who are the populations, which are the groups of the populations most affected. It's women, it's children, it's younger people. For these reasons, ICN established an initiative called Nurses for Peace just after the invasion of Ukraine. And we did that firstly because there was a very real response that nurses around the world wanted to provide solidarity to nurses in other countries who they saw in the basements of hospitals or subject to attack. It struck a chord in terms of professional solidarity, wanting to show support. But I think it also, for me and for many others, you look at those pictures and think, could I really do it? Would I stay or would I go? And the respect and the recognition of the courage and the bravery. And I use those words not wanting to fall into the trap of using the word hero, but it made many nurses absolutely think of how they would respond and react in those situations. But it also, and this is then, and I think a really important point in terms of WHO's role in this, flagged how we think about, of course, we think about the importance of delivering health and healthcare, of nurses, of health providers, as health makers. But there is something very fundamental and crucial about being health makers that leads to more peaceful and cohesive societies more generally. In the WHO Constitution, the link between health and peace is explicit in the Constitution, because when you start to unpick the causes of ill health, when you do the root cause analysis, you look at issues around inequality and poverty, lack of decent work or housing, alcohol and drug dependency issues. You can see how many of the health issues that nurses are dealing with have their root causes in exclusion, a lack of respect for rights that creates inequalities and leads to tensions within societies and communities. So talking about health as a bridge to peace, as an essential building block for peace, I think is one of the fundamental things that we need to think about in relation to how we move from this very, very challenged situation that we're in at the moment. The same is similar in relation to climate change. You'll know that this year's COP had a health day. It's historic in significance that health was recognized as central to climate change. And that's happened relatively quickly. It was only a few years ago where there was a resistance to thinking about climate change as a health issue. And of course, nurses and other health workers had a really strong voice at the COP. We had nurses there as well, because nurses see in their daily practice the impact of poor quality, air, for example, in relation to people with chronic disease, with obstructive airways disease. They see the mental health impacts following disasters and flooding as well. But if we take that root cause analysis, we're not going to fix climate change just by more nurses switching the light bulbs off in their workplaces. We need to do something about fossil fuel emissions. And that very quickly takes us as a profession to some really quite big and chunky global political issues that some would say, is that your place to have a voice, to articulate in that space? But as I say, I think that we can set out the logic and the roadmap which takes us to why it is legitimate. Two brief things then I want to say specifically about the nursing workforce, because I think the nursing workforce finds itself at the center of an unfolding ethical crisis, and Anne's referred to it, and that's the dynamic of international migration. We have 6 or 7 high-income countries who are at the forefront of driving recruitment of nurses and health personnel from countries who have significantly weaker and fragile and vulnerable health systems. The UK recently proudly said that it had recruited 50,000 more nurses to reach a target, a domestic target, but over I think it was nearly 45,000 came from countries who are on the WHO's what's called safeguarding list or red list, the most vulnerable countries where it's encouraged not to recruit from. Why? It's the result of a lack of investment in the domestic workforce, but it's exacerbating already underlying inequalities in terms of numbers of nurses per head of population. And we hear from the nurses about the impact it has on health systems. In some places, healthcare simply stops because the nurse has been recruited and unable to provide it. You reflect on that situation, and I think it gives us a slightly different perspective on where nursing is. We're in a place where we're being talked about as a commodity, where it's a trade issue, but this is going to only get worse as the gap between the supply of nurses and the demand for healthcare grows globally. And we see, and I think we've seen this through the pandemic generally as well, the global architecture that exists, the code for international recruitment in this case, but the international architecture around pandemic preparedness is another, weak, ineffective, needs to be strengthened. But then the big global political challenges in coming together on a consensus about what needs to be done globally and looking beyond national borders. And we see this all play out in the issue of strikes as well. If I go back to my starting point about, primary responsibility in the code is to do no harm, but you are the nurse who has been experienced a range of those factors that I've referred to, and you think you have no other choice. Before we get even to the rights and wrongs of it, I just ask the question, how does that make you feel as a nurse? How does it make you feel that you even have to consider a course of action where you may withdraw your services, and having signed up to a code that says that you put professionals, that you put patients first? And again, we're not going to the root causes on why that situation has developed in the first instance. There are some short-term fixes to how we deal with those issues in terms of agreements that there are about what minimum service covers should be in place. But I think there's a much bigger question that sits behind all of that, which is about the social contract and the value that we place on nurses and on healthcare more generally. So to conclude, I don't think it's ever been more difficult. I think that our profession is bang in the middle of these big global threats and challenges. We've not sharp elbowed our way in there. We've found ourselves in there. But I think that gives us a legitimacy and a responsibility to speak, to advocate. But I think there is a real important piece around how the world thinks differently about the value of caring and of health as well. And we think beyond just the health rights and benefits that come from good health care. Yes, they're all hugely. Without health, we are nothing. But without health, strong functioning economies, peaceful, stable, cohesive societies, I think are all highly questionable as well. Back to you, Sally.
Thank you, Howard. That's a very stirring and galvanizing note to conclude the presentations on. I'm just going to say I'm going to allow the webinar to run a little bit over because I think there are just so many fascinating questions here. It would be a shame if we just kept the discussion to 15 minutes. So we'll allow it to run over by 10-15 minutes. So look, there's lots of roots in here. I think I'm going to start by picking up on these 4 archetypes that Elizabeth laid out. I think it's quite fascinating to look at these narrative constructions around the care workforce. The hero and the angel, the virtue script, the wounded carer, and then the kind of evidence-based STEM knower. Now, I guess I'm curious to know from you, Anne, how do you think these sort of discourses play out when it comes to that big question you asked about recruitment, in terms of how it affects the kinds of people that apply, their expectations when they go into the workforce? Do you see those narratives? Do they sort of map onto students' understandings of what they're signing up for when they get themselves into the care professions? Oh, I think, Anne, you're on mute.
Yeah, thank you. That's a great question. Yes, they do. I think there's an issue because recruitment has gone down. After the pandemic, Howard and Elizabeth sort of alluded to, there was a lot of, regular clapping, and then afterwards there was an increase in applications because I guess people were understandably drawn to a profession and professions, I should say, that make such a significant difference to patients, families, and communities. That's understandable. But now it's not like that now. Numbers are decreasing. So I think coming back to generational differences, there still are, dare say, a lot of nostalgia. We have a program here in the UK called Call the Midwife, I think, that has probably drawn quite a few people. We don't have anything comparable in relation to nursing, but I think there still is a perception of status and doing good and making a significant contribution, and so I think around that there still would be the angelic maybe even sort of saint-like, doing good, a person of good character who will necessarily do good. But alongside that, our young people and our young women in particular, because around 90% of nurses are female, there's many more choices. So, you know, we have many more educational choices, more career choices. And as I said in my introduction, you know, people maybe don't want to work the same way that we did, you know, several decades ago. So we do. And I think in terms of the victim narrative, there has been critique of, there's just endless. I mean, hardly a week goes by, I get numerous articles on moral distress and now moral injury as well. So there is something around which has been critiqued because people said, oh, it makes nurses victims and, you know, they're suffering and so on. But nevertheless, what it is telling us, as Howard is saying, that moral distress represents nurses feeling unable to do what they feel they should do. And that does lead to often people being burnt out, having compassion fatigue, and then leaving the profession. And so I think, I mean, perceptions of young people, I mean, clearly people who come to our university are people who want to do nursing, but I still think we as a team, we discuss regularly how we manage expectations. And when we, you know, do our marketing and recruitment, we need to make it very clear that our professions are challenging. So not to mislead people, because I think if you mislead people and they come and then they don't stay, but then we also have an ethical obligation to prepare them well. And it's not just us. It's not just universities, educational establishments. We need to work very closely with our partners to make sure that our health and social care institutions are hospitable and welcoming and do support people. So I think all of these things are still around. But I'd make the same point again. Younger people are not the same, and we need to engage with their issues, with their own complexity, their own well-being issues post-pandemic, and so on, but also their values. You know, they care, they do care, and in a wider way, and I think it's a nice fit with what Howard's speaking about the environment. We need to address that as well. We're not parochial. Our young people are much more, I would suggest, globally oriented, and educational institutions need to address that and have conversations with our students about the wider issues, which includes conflict as well as the environment. So I thank you.
Thank you. No, that's fascinating. And look, I think the gender dimensions of this is something we should come back to. I mean, I was really struck by what you were saying, Elizabeth, about the kind of ambivalent consequences of these seeming compliments, of course, in terms of I mean, it also reminds me of some of the toxic discourses around teaching, another feminized profession, that sort of you can situate people as kind of being called to do something for a higher purpose, but then the moment they start demanding better conditions, they're suddenly flipped to being demonized. So I guess my question actually off the back of that to you, Elizabeth, is you set out these very compelling discourses, and you said one of the perhaps responses to them is to have kind of longer, more fleshed out definitions. I wonder, narratively, are there alternative discourses that you've seen work in terms of simultaneously providing that degree of recognition, respect that you discussed that was so important, and not oversimplifying, but at the same time giving society some sort of narrative container within which to understand the notion of care work and nursing?
Yeah, I mean, that's a really big question. And when it comes to when I'm thinking about teaching graduate students, yes, they do, because they are already nurses. I think they do appreciate the complexity of it. And they are a generation that will push back on some of the gender stereotypes. The one thing, though, that I find quite effective is when the implications for the public are shown. So when there's a clear, for instance, again, a Canadian example, our emergency rooms are really, really overloaded completely. When the experience of the public and the implications of that, and the roots of that being often the shortage of nurses. And so I think that is compelling, because there can be a representation of what nurses are doing in those settings. And I particularly like it when nurses speak to the representation of what's happening in our emergency rooms. It tends to be physicians, which is a little irksome, I mean, I'm glad that there, you know, it is a shared issue, but it's really preferable in my mind when nurses come and speak about what they do. I mean, a couple days ago, I heard a physician saying, well, then the nurses can't fulfill the orders, and then there's a backup. Well, there's a lot more to nursing than filling the orders. And so when those nurses are speaking about what they're doing in those emergency rooms, which are just a symptom of what's going on in the backup of our entire healthcare system, and the complexity of what nurses do, I think find that most compelling when connected with the implications directly for the public.
Yeah, that's interesting. Yeah, I mean, I think, Howard, I wonder, before actually I shift the conversation on, is there anything there that you want to chime in on?
Just a couple of things. I think the link to patient safety is that Elizabeth raises is a hugely critical one. One of the things we've been able to do since I've been at ICN is to connect nursing much more intimately to the global patient safety work. There's a patient safety day every year, and a couple of years ago the theme was patient safety and health worker safety, two sides of the same coin. That if you didn't keep your nurses and your health workers safe, you couldn't keep patients and the population safe. And I think that was not for all, but there was a sense before that when the risk for us when we as nurses talk about the importance of a positive work environment, safe staffing levels, absence from violence, discrimination. You know, people say, yes, of course that's right. But sometimes I might think, well, they would say that, wouldn't they? And it's in their professional interests, where being able to show, and we do have, you know, really strong and robust data that shows the connections between what we do and the outcomes for people as well. And I think that there's something bigger in there as well, which is almost what I was alluding to with the, why is it that the profession is the most trusted time and time again in polls of population around the world? It's, you know, it's people like me and other, you know, nursing folk representative will time and time again refer to these polls. And I think there is something in that, though, about the recognition of the values of the profession and the ethics of the profession as well. So, as well as keeping you safe, doing it in a way which you know, respects values which are important to all of us as people as well. I think it's really important. And then where we're going in terms of you know, during the pandemic, you know, there were those who were arguing the pandemic is a recruiting sergeant for the profession because of the positive publicity that we were seeing. And, you know, glass half full stuff, I have to say that, you know, that there was a lot of the pandemic which showed a different side to nursing in terms of critical decision making, you know, leadership, technical skills as well. And I think that was, you know, there was some helpful things in there in terms of changing people's mindsets. But equally, people who turn around and say, well, given the pay issues and the lack of vaccination and everything else, and, you know, I'm going to leave touch that with a barge pole. I don't want to go there. One of the critical issues I think we have in the profession at the moment is holding, as well as it's not just recruiting new people. We should talk more and even more about holding on to the staff that we have. The real worry is the retention and the leave rates that we're seeing amongst experienced nurses, because, you know, those you don't replace even in 3 or 4 years. These are people who, you know, 10, 20 years worth of experience, and we should be doing much more to support and hold on to them.
I think that brings us really nicely to a question that's been asked in the chat, which is which innovative ideas are out there to fight the shortage of nurses globally? So I'll open that up to anybody from the panel who'd like to respond. I mean, maybe a way of slicing this that's a little bit more manageable is to say, are there any striking examples at a smaller scale of sort of specific care settings that have adopted an innovative approach to recruitment that has sort of transformed the pool of applicants or kind of widened the pool of applicants, or has shown, on the other hand, sort of practices that have produced better retention rates. Just curious to know if there are any case studies that might prove to be inspiring examples.
Just to kick us off on this one then, Sally, it's coming at it from just a slightly different angle, but it's related to this point of retention. We see a lot of our healthcare systems around the world who, where nurses get stuck fairly low down the hierarchy soon after they graduate. There are not obvious ladders and progression points through the nursing journey. There are countries where they are much more clearly defined, but even if you take somewhere like the UK, where there's, you know, on paper there are ladders and structures, people feeling that they get stuck lower down is a real issue. And one of the breakthrough points that we're seeing increasingly around the world is the recognition and development of nursing advanced and extended roles, advanced practice of nurses who are becoming the lead practitioner for somebody with a non-communicable disease, who will be the first person, your first contact point, your triage person, your first contact point in a community setting, for example, who will be leading research and innovation within a health system, or who will have patient safety and quality improvement a part of the network. Now, all of those are their recognition of how the profession has developed, but are also using, this is one of the issues about working to full scope of practice. If people aren't working to full scope of practice, if any of us on this in this call, if day in, day out, we felt that we were being 10, 20 years in, we were being asked to do what we were asked to do on day one, we're not gonna stick around. And we've seen blocks and barriers and challenges in putting those in place. And some of that is money, some of that is gender, some of that is pushback from other professions as well. But I think we need to do much more to show people what their career progression and opportunities can be, whilst they stay within clinical practice. The routes have often tended to be into, you know, academia, to education, or to management. But if you want to stay in clinical practice, there are potentially many and varied routes, but they're not to progress, but they're not necessarily obvious or easy to get to, and we could do more there.
Thank you, Howard. Anne or Elizabeth, did either of you want to chime in there, or shall we move the conversation on?
I'll just throw in a couple of things. One is about different pathways to care careers. I mean, one thing, I'm a great supporter of apprenticeships. It's very hard now for young people to come to a university and end up with, you know, 40+ K of debt. That's not a good start. And it also deters people with experience, mature students in particular. So apprenticeships is, you know, fantastic. You stay in your place of work, you come to the university maybe one day a week, and you can then become a nursing associate or a registered nurse. So I think those pathways to care careers are absolutely critical. And as Howard said, then you go on. And I think that's also a recruitment strategy that we have to keep on telling people the story of progression opportunities in nursing, and indeed in other health and social care professions, that, you know, you might want to start as a nursing associate, you become a degree nurse, you become an advanced practice nurse, then you become an educator, a researcher. So I mean, the opportunities are phenomenal, and I think those aren't always told well enough, often enough, loud enough. So I think that's one thing. And the other, in terms of examples of good practice, thinking again about organizations, I think smaller organizations like hospices and, you know, really good residential care, fantastic, get students in there, let them see what really exemplary care looks like. And then the other thing, there's actually a study at the moment looking at Magnet for Europe, led by the colleague that Howard referred to, the work on the relationship between registered nurses and patient mortality. So anyway, so Magnet for Europe is these magnet hospitals. So you need the organizations to attract and keep and retain. So I think those would be maybe two examples that I would share. Thank you.
Yeah, very interesting. I'll just share a comment from one of the audience members, Jennifer Amby, who says that in the US, there are efforts by the government to support registered apprenticeships by building career pathways from entry-level occupations. Funding is provided to support those apprentices and also on-the-job training, so people from vulnerable communities, in scare quotes, are able to join. So look, actually, I think something that picks up on some of the responses so far is, I think I'd like to sort of squarely address this question of values and ethics. And I mean, Howard, you were talking about how part of the professional churn within nursing is the sort of moral disillusionment of being confronted with situations where you're unable to sort of live up to the values and ethics of the profession you signed up to. And I guess that leads me to question, in the face of these unprecedented challenges, this sort of perfect storm in some sense that you've sketched out, and really this is just an open question to the panel, but are the values and ethics of the profession adapted for the present moment, or do they in fact need to change? Are you seeing any movements for reform of values and ethics in light of the changing nature of care work presently? I guess that, you know, putting this another way, is now the moment to double down on the ethics and values of the profession and find ways to support it, or are there and should there be movements for the transformation of the values and ethics of the profession in some ways? Yeah, please go ahead, Elizabeth.
Yeah, I mean, this is the question, not even just now, but from teaching ethics for a long time, is how ideal do we pitch things? This is something that I've even put this as a, you know, an essay question for the students to write on. And the best I can understand for myself at this point, I think our values and ideals are fine, but educators need to be clear that they are ideals and there are circumstances in which this won't be possible. When I think of my own regulator, during the pandemic, they wrote quite a good statement about circumstances and things that would not allow people perhaps to live up to that ideal. And that's just reality. So yes, keep the ideal as a bigger vision, but recognize that circumstances may not let you practice in a way that's that idealistic. So I remember once someone saying that our code of ethics was a minimal standard. And I thought, whoa, if that's minimal, that's a huge ask. I think it's more, you know, an understanding that practice is very complicated, ambiguous, and there are times you're just not going to be able to hit that high note, if you will.
Maybe there's oh, go ahead, Howard.
Yeah, I mean, listen, I agree with what Elizabeth has said, and I cannot recall anyone who has talked to me in recent times who said that the fix or the answer to this is to change the ethics. It's, you know, the Groucho Marx solution to this. There's something about, so I don't hear that call, but I also detect something about, it's in the DNA. I know that can sound, you know, a little bit glib as well, but it's fundamental to being those values that what nurses then practice is based on. It goes deep, and it's why when nurses quit, it's often a long thought after decision. It doesn't come easy, and if they go, they don't easily come back. Because they've gone through that whole thought process about what they're giving up. But so where do we go? Where do we go? I think that there's something really important about us vocalizing much more and engaging in the debate and raising the debate when we see a clash, of values and ethics with situation. It might be happening in your workplace, it might be happening around, whether it's from climate change to short staffing, that to vocalize that, but to vocalize it in a way in which highlights you know, the different dimensions, which is not just about the individual, but what is it within the system that isn't working. I know that can sound a bit trite as well, but it's often the result of planning and management and resource allocation decisions, all big and difficult decisions that have to be taken, that are simply not working and delivering for patients. So, you know, do the good old nursing diagnostic on unpicking it and describing what you see and the dynamics of what are going on, and then stay with that discussion in terms of what you think the solution should be. I get so, you know, when we talk about the importance of leadership, of course it is. And we have these phrases about, you know, if you haven't got a seat at the table, take your own chair and be there. And, you know, it's really important. But why is it important? It's because I just don't see how do you make the best policy decisions if the largest part of your care workforce, responsible for 70% of delivery, is silent, isn't there, isn't involved? So I think some of the profession's expertise, knowledge, and ability to not only dissect and understand the problem, but then to help design the solution is, we're not doing it all on our own. I'm not saying it's all down to us, but I think we've often been underrepresented or shy of getting stuck into those sorts of debates and discussions.
So actually, I'd like to continue this conversation, but just invert it slightly. And I wonder if, and this is actually partly catalyzed by a really constructive challenge from Leslie Schwartz in the chat. I wonder if at the moment we're trying to have a conversation about the ethics of nursing and care professions, but are we in some sense kind of reinscribing some of the inequalities? I mean, I'm conscious, as Leslie says, as an African, I'm struck by how a session built about ethics and care is almost entirely a discussion on nursing by people in the global north. Obviously, most people don't live in the global north, and most healthcare is not provided by professionals. So I'm wondering here, I mean, even the way we framed the discussions around the unregulated care workforce kind of presumes our placement as people in the global north kind of discussing the ethics of recruiting nurses from the global south. But I mean, again, to this question of values and ethics, are our values and ethics up to the challenge of, in some sense, do we need to decolonize the values and ethics of nursing? Has it been developed with a particular frame in mind? And if we're saying, okay, let's actually, you know, genuinely and wholly account for what healthcare means globally, does that entail a reconsideration of values and ethics, or is it still a retention of those values but an adaptation? Would anybody like to chime in there? Please, Anne.
I'll make a start. Thank you, Sally. Yeah, really topical question. As you know, we marked the 30th anniversary of the journal last year, and we did some analysis of the changes over time. So to begin with, the submissions to nursing ethics were primarily from Europe and the North Americas. But over time, there have been significant changes. So now we get a lot of articles from the Middle East, for example. In fact, Iran, Turkey would be probably the main sources of many of our articles. However, not enough. We're acutely aware as an editorial board that our field is too narrow. So, I mean, there is a nursing ethics journal, for example, in Japan. I'm very interested in Japanese and Chinese perspectives and Confucian perspective. We have a lot to learn. But the main gap is from the global south, as our colleague has just said in the chat. Not enough. We have a colleague on the board who's from South Africa, but our reach is not as strong. But that said, I mean, in the bioethics community more broadly, there's much more conversation now about different perspectives. So in the West, we talk about the 4 principles, the primacy of autonomy, but now people are becoming aware of Ubuntu in Africa and also of Indigenous people. So that book I mentioned from Canada on leadership, there was a section on Indigenous perspectives. So we need to be much more open-minded, much more broad, much more inclusive, and much more humble. We do not have all the answers, or all of our theoretical philosophical frameworks are open to debate and discussion, and we have a lot to learn. So the short answer is there is change, but could do more, will do more, must do more into the future to have a much more international perspective on applied ethics in relation to care. Thank you.
Very interesting. Howard or Elizabeth, would either of you like to chime in there?
Well, the one thing I would say is that sometimes we do use ethics as a way of drawing a boundary around our field in the way we allow others in or out. All professions do this. That doesn't make it necessarily okay. We need to be aware of it, however. And as I was mentioning in the beginning, the unregulated workforce, which is massive. You know, that workforce, and again, I can only think about the Canadian sense in this version, and it's huge, needs a voice as well in terms of what their skills, what they're offering is huge. It's a highly diverse workforce. If I think Toronto, I think it's the most diverse city in the world. What values they're bringing in, people have called for regulation for their own well-being and working conditions and so on. So there are other workforces that we need to be respectful of, because they do, I mean, all fields cross in terms of scope. And we need to be mindful of what we're doing, because I think as nurses, you're generally more aware of people who have more power and how that affects our scope. But we need to do the same thing. We need to recognize what we are contributing to other workforces and perhaps their rights and well-being. So we need to think about this in a broad sense and a greater voice for that huge workforce.
Yeah, I think that's oh, sorry, go ahead, Howard.
No, I was just to add a couple from me as well, because I think it's a really important question, a really important challenge. I mean, our board is constituted of elected representatives from every region of the world. We've just published 2 new position statements on equity within the profession and within healthcare, again available through the website. But look, not to dodge the really tough question in this, is that, you know, the mother and founder of nursing, who we, you know, go back to as Florence, is not immune from criticism that part of the approach was based within you know, the colonial practices which are happening at that time, and it's caused in many countries a much deeper look and dive into the practices of nursing, and whether they are truly equity and equitable and equality proofed as well. When I look at the challenges of healthcare around the world, honestly, what I see a lot of at the moment in terms of solutions to access to healthcare, you know, one of the big global objectives from WHO to increase universal health coverage, you know, our Western systems are chocked full with nurses in hospitals. We need more people in the community, and the answer to accessing healthcare in many countries is about nursing outside of hospitals, and it's many of those lower middle income countries who are resource challenged, who are finding solutions to get healthcare to people in ways which are very different to how the West traditionally will have done that as well. I think that nursing is an important voice for global equity, and that's not to set us up as being, you know, a golden example. Far from it. I'm definitely not seeing that, but because of the principles of equity, which are ingrained in, back to that initial code of ethics, to see and to treat people in front of you because of their healthcare need, not for any other reason. I believe that we do have a powerful insight and leadership role to bring.
I think that was, for me, I mean, quite a striking aspect of your presentation, Howard, this idea that nursing can in some sense be a wedge for peace, a wedge for climate change. It's a route into these, you know, profound and systemic problems that can feel overwhelming. But in fact, nursing gives you a stake because fundamentally it's about health and well-being, and these systemic crises at the root of them. I mean, the reason we care is that they imperil those very things. So, you know, I think that's quite a noble calling, and certainly, you know, an interesting way of framing the profession as one that is not just seeking to help people, but also to bring about justice in a more just world, which ties in very nicely, I think, to some of these conversations around recruitment, retention, the issues that younger generations care about. I guess I'm just conscious we're coming to the end of our time, which we've already extended, and there's many fascinating threads to pick up, and I apologise to those participants whose questions we haven't been able to turn to. I'd like to conclude the discussion by picking up history. I mean, Howard, you mentioned Florence Nightingale, and you said in your presentation that in some sense, you know, to rephrase, you think that part of the challenges that the care workforce is confronting comes down to the nature of the social contract. And in some sense, we're at perhaps a kind of low point or a low watermark. I'm curious to know historically, how has that changed, and when was the high watermark of this social contract between nursing and the public? What are the sort of historical examples that we are drawing upon to kind of understand when nursing was flourishing at its best. I'm just curious if the panel has any thoughts in that regard.
Can I just make a couple of quick comments? Yeah, and I think historically, someone's also put a comment about the relationship between nurses and doctors, and a Nightingale again, discussion of loyalty and subservience. You know, the nurse is the eyes and ears of the doctor. Well, those days are that's in the past. However, there is a perception that early nursing ethics was sort of along those lines, but actually Marcia Fowler's recent work has shown that early nursing ethics was a social ethics. So early nurse theorists were engaging with some of the big social justice issues of their time. So I think we're going back to this and we're much more open about that now. So I think, yeah, historically, whenever you relook again at early literature, we find that actually they were discussing many of the issues we're discussing today. But that said, there's still progress to be made. Yeah, thank you.
That's fascinating. So yeah, in some sense, what we're talking about is kind of coming full circle.
I agree, and some of my colleagues often hear me say that the founder for ICN, a woman called Ethel Bedford Fenwick, was a suffragette, and she was inspired by the women's global movement back in 1890s, the 1900s, to say, look, you know, nursing needs international organization and voice, because it's not just health, it's these other issues. So a lot of what I've said, I absolutely would not want to make any suggestion or claim any type of credit for say this is some sort of new thinking from us. When I look back at our history, I see it as a very natural extension and application of that philosophy, those values, of those approach in a modern day setting. I guess some of the history stuff that frustrates me is that when there are, and the pandemic is one of them, and the Spanish flu in countries that have had experienced things like, you know, MRSA outbreaks as well, in situations of conflicts and disasters where there is a big focus on health and people see the importance of health, but it's then following through afterwards. We seem to go back to business as business as usual, as opposed to following through and saying, really, what have we really learned from this experience and what has happened? What do we need to move on in terms of our practice, our preparedness, looking at our ethics, the way that we're investing? And my sense of alarm, I suppose, about where we're at the moment is just because it doesn't feel like there's any obvious normal. When I say we're going to go back to normal, I don't feel that comfortable about what the next few years might be in terms of what normal is. And I'm not a scaremonger on any of this and don't want to sound like reactionary or alarmist, but the increasing conflicts around the world and what may be happening in, you know, within one particular region of our world, combined with climate change, global economies struggling to grow and develop as well, our vulnerability as a profession and health's vulnerability, all this feels really quite risky for me. So the importance more than ever before of articulating and learning those lessons and trying to do things different for the future I think is where I was coming from.
And remembering those lessons, we're notoriously forgetful as humans, aren't we?
Yeah, and also I think building on what things Howard and Anne have been saying, it's also looking globally. What are histories that we don't know about? So perhaps there are places in the world who have figured the social contract out better than we have. So I mean, there are many things to consider here. You know, I can't think of, I was trying to think in my mind of a high point. I mean, we've always struggled with certain things, but it is a bit of a low point right now, for sure.
At the same time, I think, and I'll just to conclude at this point, I mean, I think something I've taken away from the discussion is kind of, if you reflect of the state of global politics, I mean, a lot of the sort of toxic ethno-nationalism that we're seeing bubbling up is all about pitting different interest groups against one another. But what strikes me when we talk about the crises or challenges confronting nursing and the care workforce is that these questions around how does one advance gender equality? How do we uplift Indigenous voices? How do we address environmental justice? How do we give voice to migrants? These are all actually can generate positive feedback loops that can improve outcomes, can improve conditions for care workers, can improve outcomes for patients. So in some sense, despite all of the negativity that that we're confronted with in the headlines, I think actually there's a really good news sort of message here to take away. And you know, I'm hopeful that that as Howard, Anne, and Elizabeth have set out, that there are kind of ways of reframing care and ways of uplifting workers that we can kind of use as sort of one beachhead, if you will, in this very complicated interwoven struggle. So I thank you all to the panelists for this fascinating discussion. I feel it could have gone on twice as long, but I don't want to stretch everyone's patience. Thank you to Brochure for hosting this series, and thanks to all of the participants for your really thoughtful and engaged questions. I'm sure that you can contact the panelists afterwards if you'd like access to any of their presentations or have any further questions. So thank you all for a really enlivening discussion, and have a great rest of your day.
Thank you, Sally. Thank you all.
Bye-bye.
Lovely to be
Thank
part
you.
of it.
Bye-bye.
Thank you. Bye-bye. Thank you.